Welcome everyone to part 2 of RV, CVP, and EKG. We're going to take a look today at some central venous pressure, some of the abnormalities that you can see, how to actually appreciate them and correlate them to your 12-lead EKG in patients who are presenting in a little bit more difficult way. Sometimes it's harder to figure out what's going on. We are very cardiocentric. We are always thinking that it's a left heart problem when very frequently it's a right heart problem. And that's how we're going to use our CVP trace and our EKG evaluation in this patient population. So just as a reminder, now this is really talking about MI, but overall, what I want you to remind yourself is that when you are clinically evaluating patients, you want to keep in your mind the difference when we have a left ventricular failure or a right ventricular failure. Now, patients don't always obey the rules. This is not absolute. It's a little bit variable. Things can change. But typically with pure LV failure, especially new onset, the primary problem is stasis of volume in the pulmonary veins. So the patient has pulmonary congestion. Whereas with the right ventricle, the stasis of volume is in the systemic veins. So the lung fields early on could be clear. Breath sounds are good. Chest x-ray looks good. However, the patient has gained weight. He has bilateral pitting edema. He may have hepatojugular, positive hepatojugular reflex. He may have many things. But what's most important is that with an individual who has right ventricular dysfunction, whether it's an MI or whether it's pulmonary embolism or acute pulmonary hypertension, what will happen is the right ventricle will become overstressed. And the right ventricle was never designed to actually be able to accept a fair amount of stress. It does not actually manage stress very well. And so what you often will see is ventricular dilation and a new onset tricuspid regurgitation. Now, I work in an ICU. I've always worked in an ICU. I can't hear anybody's heart sounds in the ICU. And that's, of course, quite important because you're not going to really make this differentiation by heart sounds, although you could if you had a really great stethoscope, probably a microphone technology stethoscope, you would be able to hear the regurgitation and identify that it's the tricuspid valve. Hear a third heart sound and identify that it's a third heart sound, which is mostly affected during inspiration. So really, really important to focus on the three common things. Your CVP with right ventricular dysfunction, whether that is primary, meaning it's the right ventricle that has a problem, or secondary, meaning it's the left ventricle, and now the right ventricle is involved. So in both cases, you will get an elevated CVP. Now, I'm going to consider a CVP to be elevated typically when it's greater than 10 millimeters of mercury. From 5 to 10, I'm going to consider that to be a relatively normal CVP, and anything less than 5, no matter what, I'm going to consider is an indicator that a patient is hypovolemic. So I work by 5s, right? 0 to 5. If your CVP is 0 to 5, here's the only time where CVP can be used for indication of volume. If your CVP is less than 5, your patient is probably hypovolemic. From 5 to 10, we're going to consider that to be essentially normal. And anything greater than 10 is going to indicate to me some loss of right-sided compliance. Now, what that could mean, when I talk about the right side, I'm talking about the pulmonary vessel, the pulmonic valve, the right ventricle, the tricuspid valve, and how that's all reflected in the right atria, in the right atrial, or the central venous pressure. So number one, elevated CVP, my friends, do not assume that an elevated CVP means your patient has too much volume. He may have high volume load in his veins. He may have high volume load in his interstitium, but CVP typically above 10 indicates loss of right-sided compliance. And that means pulmonary vessel, pulmonic valve, right ventricle, tricuspid valve, right atria. Oh, that's a lot to unpack. And a lot of things affect that. But remember, when you come to the bedside, you connect your pressure tubing to the brown lumen of your central catheter. you are going to get incredible information, generally not information about volume, but information about compliance and things that are going to happen to the right heart that will then be reflected in your CVP. Unpacking the CVP a bit further is the waveform analysis of your CVP. It's the same kind of waveform analysis one would use if they actually had the pleasure of working with a PA catheter and a pulmonary capillary wedge trace. Wedge trace, pulmonary capillary wedge, right atrial pressure, those are both venous pressures. They are looking at the way venous volumes flow into the atria, which ultimately flows into the ventricle. CVP looking at right atrial flow to the right ventricle, wedge pressure looking at pulmonary venous flow to the left atrium and into the left ventricle. So really important for us to appreciate that when we're evaluating our patients and trying to understand the general presentation. So first and foremost, an elevated CVP above 10 requires an investigation for right ventricular or valvular dysfunction. Abnormal waveforms in the CVP are going to help you identify, is the problem your valve or is the problem your compliance? And you're going to be able to do that if you really pay attention to waveform analysis in your CVP. The third heart sound, so remember the third heart sound is the sound, it sounds just like lub and dub. So it's not a murmur. Murmurs are shh or a or shh or a. Third heart sound isn't a lub dub type sound. What is really important about the third heart sound is that when blood empties into the ventricle early in ventricular filling during diastole, the ventricle should be generously accepting that, nice and stretchy. But when the ventricle becomes non-compliant and blood drops from atria to ventricle, you hear a third sound. Lub dub dub, lub dub dub, 1, 2, 3, lub dub dub. And that third heart sound can occur close to the second or much farther from the second heart sound. It's known as the diastolic filling sound. And ventricles should fill easily on diastole. The time that they don't is when they're stiff. Right-sided heart sounds are louder on inspiration. So that's really important for us to remember. That's how we can tell the difference between a right-sided or a left-sided third heart sound. And again, requires a lot of expertise. You have to listen to 1 million hearts. 10 cardiologists listening to the same heart are going to have 10 different definitions. So it's not quite as valid or valuable to us as actually being able to look at the CVP, look at the waveforms in our CVP analysis, and make good decisions as they relate to that. Okay, so just as a reminder about CVP, CVP is the pressure that is measured primarily in the central veins or in the right atria as a reflection of how your right ventricle fills. Okay, now we're going to remind ourselves, CVP, right atrial pressure, CVP, is an estimate of right ventricular filling pressure. So two things that affect that: compliance of the ventricle and the volume that fills it. Okay, so really important to remember, CVP isn't only about volume, CVP is about compliance. And again, the most straightforward thing I can say to you is whenever a CVP is greater than 10, you have to ask the question about whether or not the ventricle is compliant. Now, lots of things happen to the ventricle that make it non-compliant. Positive pressure breathing, right ventricular infarct, pulmonary embolism, pacing, junctional rhythms, lots of things happen, or not junctional rhythms, sorry, but pacing. Lots of things happen to our patients that actually make the right ventricle relatively non-compliant. If we are only trying to apply CVP as a volume measure, we are doing our patient a terrible, terrible disservice. So I want to remind you that whenever you measure pressure, it is about volume and compliance. And the right ventricle was designed to hold a lot of volume without an increase in the filling pressure, or what we call the preload pressure, pre-ventricular ejection, the preload pressure. So I want to make sure that first and foremost, we appreciate central venous pressure is about the reflection of pressure that is generated when the right ventricle is filling with volume. And whatever can affect volume and whatever can affect ventricular compliance will affect our CVP. So Our right ventricle is typically a very compliant chamber, and you have to have a certain amount of volume to fill it to achieve a normal CVP, which would be about 5 to 10. Some folks might say 8. I say 5 to 10. I'm going to give a little bit of space instead of making it so narrow, because we want to be sure that when we're communicating, we're using numbers that actually are going to drive a difference in practice. Okay, so I love this little picture. Just to remember, volume of blood in the ventricles at the end of diastole is the stretch of the ventricle in relationship to the volume. So preload pressure is about volume and compliance. Afterload is the amount of tension the ventricle has to generate to eject blood out the valve. And if we're talking about the right heart, that will be out of the pulmonic valve and into the pulmonary circulation. And then, of course, the power of contraction, which we really can't measure. We just assume. We assume the power of contraction by looking at cardiac output or by looking at stroke volume. Now, we're not talking about either one of those things here today. We really are only talking about how can we use CVP to give us a better idea about what's occurring in the right heart. And we're always going to remind ourselves that CVP, which is measured in the central vein, or right atrial pressure, which could be measured with your central line, is also measured when you use a PA catheter, that right atrial pressure, one step closer to the RV, is a reflection of the pressure that is generated as the RV fills with volume. Let's remember, not only volume, but in the case of the RV, compliance is incredibly important. Now, we think about our central venous pressure, and although you might not be looking at this, partly because you're not adjusting your scale to fix your picture, and we're going to see a few of those, you can see here I've got a scale of 0 to 15. This is an artist rendition. I didn't make this. And what I'm looking at here is central venous pressure. And central venous pressure has 3 uphills, and I'm only going to talk about the 3 uphills, the A wave, the C wave, and the V wave, and 2 descents, the X and the Y. I'm not going to talk about this H over here, which is a plateau phase, which really is not going to be that important to us, okay? Now, I want to remind you that for all mechanical events that happen in the heart, they must be generated by an electrical event. Okay, so first and foremost, you must have an electrical event to have a mechanical response. You must have an electrical event, that's what we're going to call our EKG, must have an electrical event to have a mechanical response. Now, you can have an electrical event. You can have a normal sinus rhythm on your monitor and not have a contractile response. That's known as PEA, right? Pulseless electrical activity. But you can never have a mechanical response without electrical stimulation. The electrical stimulation that we visualize on EKG is ultimately about opening some channels for ions, and those ions being calcium, to move into the myofibrils to allow for contraction to occur. You must have an electrical response for that to happen. So electrical always precedes mechanical. Now that's important. Electrical always precedes mechanical. What that means is that when I am looking at a dual channel recording of EKG and CVP, I know that the P wave reflects the atrial distribution of current, and immediately following the P wave during the PR segment, not interval, that's from the beginning of the P to the QRS, the PR segment, that's when the atria contracts. When the atria contracts, the atrial chamber gets less compliant and the pressure goes up. P wave causes atrial contraction. I visualize that in my CVP as an A wave, the pressure increase in the atria on atrial contraction. P wave causes A wave. P wave causes A wave. They don't occur at the same time. Electrical event happens first. Mechanical response is occurring during the PR segment, and that's when I see my A wave. So if I drew a line straight down from my P wave, the first waveform following that would be my A wave. The electrical event, the QRS of ventricular depolarization, is associated with an increased pressure in the ventricle and a reduced pressure in the atria. And that causes in the case of the CVP, causes the closure of the tricuspid valve. That's known as the C wave. So it's not hard. A wave, atrial contraction, C wave, closure of the valve. And then, because I'm not actually in the ventricle, I'm looking at the atria fully relaxes, and I get my first descent, and that is the atrial relaxation descent, known as the X wave or the X descent. So atrial contraction, closure of the valve, atrial relax, X, relaxation, okay? And then my ventricles, right? So I've had that electrical response. Here it goes. And just before I have the electrical signal for the ventricle to relax, at the ultimate peak of ventricular ejection, I get a valve bulge up into the atria. And as the valve bulges up into the atria, it makes the atria smaller, and that instills the V wave. Following the V wave, I have another relaxation event as the valve bulges up, and then the valve opens, and I have another event. It's basically a relaxed event, but actually it is atrial emptying. 2 Y's in that. Emptying. Boy, I'd be great on whatever that thing is where you choose your cards and make your letters. I don't know. I can't remember the name of it right now. Oh, that was Pat Sajak. Okay. And Vanna White. Just can't remember the name of the TV show. Okay. So how fantastic is this? P wave causes atrial contraction. That's the A wave. QRS promotes the closure of the valve. That's the C wave. The X descent is atrial relaxation. The T wave is correlated with the max up of the valve right before valvular opening. That's the tricuspid valve. That gives me the V wave, followed by another descent, and that's called the atrial emptying. That's the passive filling of the ventricle. A wave, C wave, V wave, X descent, and Y descent. Now, in nursing school, if you've ever gone to a hemodynamics class, somebody's talked about this. I'm sure someone's talked about it, but they don't really put it into the reference of importance. And here's the reference of importance. When the A wave is significantly bigger than the V, and that would generally be 2 millimeters or more, A wave, 2 millimeters or more bigger than the V, you have a loss of compliance, period. A wave gets bigger. If it's in the normal process, the A wave gets bigger because you have a loss of compliance. That may mean the tricuspid valve is stenosed. It may mean that the right ventricle is hypertrophied. You might be pacing. You have loss of right ventricular compliance because of a right ventricular MI. You have loss of right ventricular compliance because of pulmonary hypertension. Lots of reasons. All I want you to remember is when your A wave gets significantly bigger than your V, the atria is contracting harder. The atria has to contract harder when it has to create more force to move blood from atria to ventricle. That's why your A wave gets bigger. Your V wave gets bigger than your A, and again, 2 millimeters or more bigger than the A. Your V wave gets bigger than your A wave when your valve regurgitates. Okay, that's it. That's all. But how incredible is that information for you? Because it really changes the way you look at your patients. Now, the X descent and the Y descent have a lot of importance. C wave has a little importance because it just indicates the closure of the valve. Remember, if you've got a stenotic valve, it never opens, so it doesn't close. You don't get a C wave. If you have valvular regurgitation, the valve barely closes and then it regurgitates. So really important to appreciate these kind of smaller idiosyncrasies. But just in general, I would be joyous if any person that was on this call called me and said, hey, Barbara, I saw a big A wave. Hey, Barbara, I saw a big V wave. That changed the way I talked to my provider. It changed what we were doing. Fantastic. That's what it's really all about, right? Lots of reasons to understand central venous pressure because you get so much glorious information. So this is kind of a more intensive component than I wish to go to, but just A wave means atrial contraction after the P. C wave is the tricuspid valve bowing up into the right atria after the valve closes. And the V wave is that valve bowing upwards just before opening, causing a significant increase in pressure. So these are the components that we really want to think about. It is really important for us to know about X descent and Y descent. Might be a little bit beyond the topic of this talk, because I really want to be sure we're getting A waves and V waves first. X descents and Y descents are really important. We're going to see some patients that have alterations. Okay, so again, 3 positive waves, A, C, and V, meaning upright. And then negative tracks or descents would be the X, and there's X1 before the C, and X before the C, and X1 after the C. We're just going to call that X. We don't need to get that intricate. Just call this whole thing sloping down the X and sloping down after the V, the Y. Remember, X for atrial relaxation, Y for atrial emptying. Okay. All right. So again, taking a quick look at this, I want to tell you about the number one reason you see a big A wave. So if you're looking at this CVP right here, you can see you've got this one big waveform that has to be correlated to the EKG. You can't just look at a trace and say, oh, he's got a big A. It's got to be correlated to the EKG, and we don't have the EKG here. But so trust me, P wave occurred here, the line down. Here was my A wave. And a large A wave, you can see that's bigger than 2 millimeters, bigger than any other wave. Prominent A wave, number one issue is resistance to right ventricular filling. Resistance to right ventricular filling. Now, that can occur because you have tricuspid stenosis, you've had an RV infarct, you have pulmonary hypertension, you have pulmonic stenosis, you have a cardiac tamponade. So knowing that you have an A wave doesn't give you the end diagnosis. Knowing that you have a large A wave tells you that you have resistance, and it's your job to figure that out. Oh, you've got a tamponade. Oh, you've got acute onset pulmonary hypertension. Oh my God, I saw it in the CVP. If your patient's in a junctional rhythm, if they're having ventricular dysrhythmias or they're in complete heart block, which means now there's a dissociation, if your atria is contracting against a closed tricuspid valve, you will get something else, and that is known as the cannon A wave. Like you shot it out of a cannon, it's a really big waveform, and it's going to really obliterate the value and the meaning of your ventricular filling pressure, because your cannon A wave may be huge, but your actual volume in your ventricle may be low, and that's why we really have to understand these waveform analyses. Okay, now you're going to remember this is what your normal C wave looks like. Here's your A, then you descend down, you got your C, you descend down, you got your V. Okay, A, C, V. And these are expanded, they're drawn by artists. But here's the thing, your C wave and your V wave become part of the same visual when you have a regurgitant valve. So many of our patients have very profound tricuspid regurgitation. They have pulmonary embolism. They have acute or chronic or acute on chronic pulmonary hypertension and RV infarct, and all of a sudden they are regurgitating. If I came in the room and I saw this picture, the very first thing I would want to do is I want to look at your echo, because I want to see, do you have validated tricuspid regurgitation? Yes or no? Did this look the same as it looked yesterday? Yes or no? Now my stethoscope goes on your chest, and I might call the cardiologist and say, you know, yesterday I had an A wave, C wave, and V wave that were really well defined. And now I have a C and V wave that are very tall and that are actually presenting to me the probability that my patient has acute tricuspid regurgitation. Okay, remember that X descent? That X descent should always be the biggest descent. So A wave, C wave, X descent. Usually that means you have good RV function. If you don't have a dominant X descent, meaning that's the biggest descent, here's your X descent, here's your Y, here's your X, Here's your why. X-descent should always be the biggest because if the right ventricle is relaxed, the atria can also relax very significantly. So that's really, really important. That's really all I'm going to say about that. It plays a major role in diagnosis of cardiac tamponade and constrictive or restrictive pericarditis. Again, a little bit beyond where we are now. But here's the other thing I want you to remember about that V wave. So that V wave here is as the valve bulges up into the atria. But if you have significant tricuspid regurgitation, what you're going to see is that marriage of the C wave and the V wave, and they're going to be very, very tall. Sometimes you'll walk in the room. Sometimes when there's a really big V wave, a doc will walk in the room and go, well, where is that catheter? Is that catheter in the pulmonary artery? Is it in the right ventricle? No. By x-ray, we can see it's actually in the central vein, or in the tip is in the right atria. But I have a patient now who's got very significant tricuspid regurgitation. So that's going to be a really important concept. Okay, so let's take a look at patient number 1. You can see here I am. I've got a heart rate of 75, nice arterial pressure. I've got a pulmonary arterial catheter, 36/11. Pretty good, a little bit high on the systolic side, but the diastolic side is quite nice, telling me that the probability is I don't have pulmonary hypertension. I look at my CVP number is 5. Of course, I always want to be sure my equipment is right. I'm leveled, I don't have any air bubbles. I'm pumped to 300 millimeters, not more, not less. 300 millimeters in my pressure bag, which maintains the constant opening of my transducer and the constant flow of volume at 3 cc's an hour into the patient. Now I'm going to say, I'm looking at this visual, and I'm going to say, here's my P wave. It's not a very good picture of a P wave. And there's my A, and there's my V. There's my A, there's my V. And I have to actually do this not on a monitor. I have to be able to lay it down on graphic paper, 2-channel recording, and correlate. But you can see, and you know, I said that was the A, but that wasn't the A. Here's the A, X-descent, V wave. A wave, X-descent, V wave. A wave, X-descent, V wave. Don't really see a C wave. I'm okay with that. I'm not that worried about the C wave, and I don't really look hard for it. Patient looks pretty darn good. He's got a nice normal CVP. He has lovely waves. Might be a little bit low. If I'm concerned, he has a base deficit. His urine output is low. His pressure looks pretty good. His diastolic pressure is low, but I might give him a little bit of volume. I might give him a volume challenge and see, does he have some improvement? Okay. Now I look at this patient. This patient, not so great. This patient doesn't look so good. I'm going to start off with his EKG. By the way, I don't really see any P waves here. Okay, so if you don't have a P wave, you can't have an A wave, because you got to have a P wave to have an A wave. Okay, now my patient's pressure is 160/66. He has significant pulmonary hypertension. And even though I don't have an A wave, what I can see is that his CVP is quite elevated. Okay, it's 17. Now, remember, I said anything greater than 10, you need to investigate for loss of ventricular compliance. Well, we already know what our problem is. Our patient has pulmonary hypertension. That's reflected back to the RV and ultimately reflected to the RA. Very likely that the patient's arterial volume is low and his venous volume is high. He's gained weight. He has interstitial edema. He might even need CRRT. I can't find an A wave well-defined here because it looks like a junctional rhythm, but I do have this evaluation here that tells me that the right ventricular pressure, filling pressure, which is reflected in the right atria, is of concern. But before I make any decision, I'm always going to go over here and say, is this the right scale? The scale is the window at which I'll look at the pressure, and the pressure is 17, so the scale is 0 to 20. That's perfect. This is an optimized scale. It's the right scale for the waveform. The other thing I'm going to do is I'm going to make sure that there's no air bubbles in my system, that I'm level, and that my pressure bag is at 300 millimeters of mercury. Now, I can also do a square wave test. I'm not here to talk about square wave tests today, but if you've been on before, if you're ever on again, you'll hear a square wave test is when I actually change my scale to 300, pull my pigtail, and see that I get a square wave, the top of the wave actually at 300 millimeters of mercury, which then tells me that my equipment is okay, not the patient. the equipment. But I always want to remind myself, I'm looking at that EKG. I don't see a P wave. Sometimes I see this little mark, but it's not really constant. Now, in this instance, I would want to do a 12-lead EKG to really look at what's occurring for the patient. Okay, now this is a patient, I'm going to call her TS. We're going to see her again at the end of the talk. Okay, so we're going to see her arterial pressure, which is in the wrong scale, right? Her pressure is 107, but the top of her scale is 90, which is why she's squared off up here. So first thing you do is you want to adjust her scale. Then we go down, we look at her CVP, and in her CVP seems to be almost people would say, oh, look, she might be an AFib or there's a lot of noise. No, what you're actually seeing is an A wave, a C wave, and a V wave, and you're seeing it in groups of 3. So her value is a little high. Again, always be sure you're level, that you're no air bubbles, your pressure bag's at 300. You do that every time you look at a pressure. You need to assure your equipment is right. Okay. But here you see, and I'm going to try to draw a straight line if I can. Okay. There's her A wave or C wave or V wave. Okay. So the biggest one, which is what you expect, A wave, C wave, V wave, A wave, C wave, V wave. And from A wave all the way down to here, so the C wave interferes right there, but A wave all the way down here is her X descent. And then I'm going to tell you, she's got a PEEP of 12. Okay, well, she's on a PEEP of 12. That positive pressure in the thoracic cage is going to be communicated into the central vein. And that's part of the reason her central venous pressure is high. And then we just go back and we have one more. I'm sorry, I probably had some shaky hands when I was shooting that. I'm going to leave that one alone. Okay, I'm going to go over here and I'm going to say, on this patient, I don't have his EKG, but trust me, this is his A wave. Okay, so here's his A wave, here's his C wave, here's his V wave, and the A wave is at around 4 millimeters higher than the V wave. You have a large A wave. So what I'm going to investigate when I see that, what I want to know, and I'm going to do that in a forward or a backward condition. Does my patient have an EKG with right ventricular hypertrophy or right bundle branch block? Okay, those are the first things I'm going to do. That's really easy. All I have to do is look at your EKG. I don't have to think too much. I can just say, oh, is there evidence of right ventricular hypertrophy? Meaning that on the right sided lead in V1, you have current coming to the right. That gives you that upright wave. That is your R wave. You should never have an upright wave in V1. If you have an upright wave in V1, the next step is it wide or is it narrow? This is narrow. So upright wave in V1, as long as your electrodes are on correctly, and of course you need to make sure of that, this is right ventricular hypertrophy. Over here, I have a big upright in V1, but it's wide. It takes a lot of time. This is right bundle branch block. With RV hypertrophy or right bundle branch block, you're going to get a big A wave in your CVP. I walk into your room in the morning, I'll look at your bedside monitor, I see a big A wave. The first thing I'm going to do is I'm going to look at your EKG. Is there evidence of right ventricular infarct? Is there evidence of right ventricular hypertrophy? Is there evidence of right bundle branch block? It means you need to be just even passingly familiar with how you diagnose that on a 12-lead EKG. And you're all invited to take 12-lead EKG with me or any other great instructor in the world to really learn how to differentiate these things because they so profoundly impact what we're doing. Because our docs would say, oh, most of my docs would say his CVP is 12, I'm not going to give him volume. But his A wave is large here because he has a right bundle or he has right ventricular hypertrophy. So he may actually be functionally hypovolemic, but the A wave is pulling the average up, and the average is what is being displayed by the monitor. Okay, so now I'm going to take a look at this patient. This patient has a ventricular pacemaker. Now, you might not know that right off the bat, so you got to make sure you're looking at leads where the pacing spike is really visible. So typically we look for RV pacing spikes. The place they're most visible will be in your inferior leads, leads 2, 3, and AVF. And you all can see here, you have a ventricular pacing spike. This patient is in 1-to-1 pacing. Okay, so functionally, We don't care about the patient's P wave anymore. It looks coincidentally every once in a while like the P wave is correlated. It looks almost like your pacemaker is timed to the P wave, and that would be fine. You could have an AV sequential with a normal P wave and then a ventricular spike. But what actually happens here is this patient is not with an AV sequential. He just has a basic transthoracic pacing wire embedded into the right ventricle. So electrical current is going from the apex of the ventricle up towards the base, and frequently that means your valves will be closed. So now we look at our CVP trace in this patient. This is not his EKG. I don't have his 1280 EKG. This is just a pacing EKG. This patient is being paced. And what we see here is what we call canon A waves. So the atria is contracting against a closed valve. That's the problem, of course, with ventricular pacing, because you're not timing the atria and the ventricle. There's no timing correlation. You're just pacing, 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 and the atria is contracting, but those are often dissociated. And so what you're actually going to see are these great big A waves. Okay, look at my scale, 0 to 20. I'm not worried about a square wave signal or anything else, because all I'm really looking at here is what is my scale, and look how big my A wave is. And when I look at the patient, I say, oh, he has a big A wave because he's paced. Okay, right bundle branch block, right ventricular hypertrophy, and pacing. Easy things to rule out just by looking at your EKG and understanding these relational dynamics and how incredibly important they are. And then we're going to look at this patient. Okay, this patient also has canon A waves. And the patient, okay, hang on one second. Sorry about that. So let me just go here and pull that down just while you're looking at that. So in the beginning of the strip, you can see that your patient has a junctional rhythm, and then they actually have a normal sinus rhythm. And look at the transition right here. You can see where the difference occurs. When he has a junctional rhythm, he has a canon A wave because the atria is contracting against a closed valve. And then once he goes in a normal sinus rhythm, he goes back to a normal ACV morphology. And you saw that happen. You say, well, what's wrong with that? What's going on with that patient? So again, understanding your EKG and correlating that to whether valves are open or closed and whether ventricles are compliant or non-compliant is the beauty of your CVP. For this one, for the first half, the patient's in junctional rhythm, or the first 2/3 really, and the last 1/3, the patient's in a normal sinus rhythm. And look at that A wave. So by the way, your monitor doesn't understand that this is a big A wave, or I'm sorry, that this is a big A wave. It just looks from the top and the bottom and gives you an average. So it's telling you that the average CVP, let's assume that we're on a 30 scale, that your average CVP is around 18. Whereas once you go into normal sinus rhythm, you can see that your overall pressures drop significantly because now you lose that canon A wave. Okay, wanted to show you tricuspid regurgitation because I did not have a great waveform. So I'm going to stop sharing. I'm going to hopefully connect here. And I've got to start sharing again. So let me get back to my Zoom. It's a lot of manipulation. Sorry about that. Share my screen. And this is from someone's Twitter account, but it's like the most gorgeous thing I've ever seen in terms of talking about severe tricuspid regurgitation. So looking at the patient's neck veins, you can see A wave, V wave, A wave, V wave. The little bump down here at the bottom is the A wave, and the big bump here is the V wave. And when we look at his CVP, his C wave and his V wave are merged together with a really big upright, right? So really, really, really important to remember that normally you would see ACV ACV, but now you are regurgitating from the right ventricle through the tricuspid valve, and you even see it significantly in the patient's neck vein. And that gives you this merge of your C wave and your V wave. Again, physicians might come in the room, you yourself might come in the room, your colleagues might say, oh, look, this can't be CVP. Well, first of all, look at the x-ray, see where the tip of the catheter is. Catheter's in the central vein or in the right atria, it's CVP. Can't be anything other than CVP unless it's from a PA catheter. But with just a triple lumen catheter, it cannot be anything other than CVP if you've got this waveform. This is severe tricuspid regurg. Now, your patient is regurgitating backwards instead of moving blood forward. So everything you're going to do about this patient is going to be a really important concept. Okay, I'll go back to sharing my screen. Hopefully you saw that. I couldn't tell for sure. Okay. All right, so really, really important as we look at our patients to appreciate, understand, value the fact that we want to monitor with purpose. If my patient is going to go under the risk of receiving a central catheter, and by the way, there are many times that risk-benefit ratio are absolutely 100, profoundly important, very, very important, and frequently that's going to be really, really important. And so I want to say, if I'm going to allow the risk-benefit ratio for my patient, I want to utilize monitoring with purpose. I want to remind you that I might only have a central line. I don't even have to be in the ICU. I could be in the ECC. I could be in the step down. I've got a central line. You put that central line in, it belongs to me. That brown lumen, I'm going to attach to a stopcock, pressure tubing, pressure bag, and I'm going to monitor. If my patient has good oximetry, he has a good SpO2, his chest x-ray looks good, his breath sound clear, but his CVP is elevated, that is telling you that you have right-sided dysfunction, okay? Now, there's a lot of criteria here, a lot of criteria. I just want you to remember, when you get a pressure that's greater than 10, your patient is going to look volume overloaded because he's going to have venovolustasis. He's going to have peripheral edema. He's going to have abdominal edema, intracranial edema. But it isn't necessarily that he has too much volume. He just has too much volume for the non-compliance of his right heart. You try diuresis, the patient makes no urine. That volume didn't move from right heart through the pulmonary vault to the left heart. You should be paying attention to that. That's a really important sign to us that we have a patient who has some loss of right ventricular function, and we see that in our CVP. Okay, so now I'm going to come just a few seconds more to our patient. Our patient had a cardiac arrest per EMS. The family said the patient was talking to them at around 7 p.m. on 3/18, and she suddenly fainted. EMS arrived. They call EMS around 1907. So EMS gets there like in 7 minutes, and patient was found to be in a systole. They, of course, started CPR, started some therapies. Patients in a systole goes into VF, back into asystole, gets shocked, has return of spontaneous circulation, goes back into asystole, gets 1 of epi, and finally gets a pulse, gets 4 more rounds of epi, 50 of fentanyl, an amp of bicarb, and 1 of calcium while en route to our emergency room. Blood glucose is 205, patients intubated by EMS. These are advanced paramedics. She has a history of CHF and kidney failure, and apparently no dialysis at this time. Now, I don't know what that meant. Was she on dialysis? Does she get dialysis? Didn't really understand what that note meant. But when she comes to the hospital, we look back at her history in 2011. So this is just a couple of weeks ago. This was 3/18. Her right heart cath in February of 2011. Wedge was 18. Mean pulmonary pressure was 57. So left heart looked okay, but the mean pulmonary arterial pressure was 57. Okay. Right ventricular systolic pressure was 102. Now, your right ventricle normally generates a pressure of 20 to 30. Your pulmonary artery systolic pressure is typically 20 to 30. But you got a mean pressure of 57, which meant you had a pulmonary artery pressure of somewhere around 80. which is extraordinarily high, putting a huge workload on the right heart because the right ventricle is meant to generate pressure of around 20 to 30 to eject blood. But the right ventricular pressure in 2011 was 102. The systemic blood pressure was only 116. So your right ventricle basically is transformed into a left ventricle. And it's working really hard to move blood and push that up into the pulmonary vault. Okay. So in 2011, they put the patient on a nitric oxide trial. Nitric oxide, not nitrous, that's laughing gas. Nitric oxide, when inhaled, is delivered directly into the alveoli and then into the pulmonary vasculature and promotes pulmonary vasodilation, has about a 5-second half-life. So it does not affect the systemic pressure. So they put her at 30, which is max, close to max dose. And her PA pressure, mean pressure, dropped from 57 to 47, but it didn't go below 40, which is what you want to see when you give somebody a pulmonary vasodilation trial. So she's only partly reactive to pulmonary vasodilation, even though her cardiac output increased at that time. Now that's all history. That's all history. She was diagnosed as having chronic pulmonary hypertension in July of 2012. Okay, now we're talking about 2023. Okay, so she has had a cardiac arrest. Here's her first EKG on 318 at 2100. And you can see that this is a difficult EKG to read, can't really evaluate it very well. She basically has an idioventricular rhythm, might look occasionally like the P wave is matching, but it really isn't. You can see the PR intervals are a little bit variable. And mostly I would want to look at this rhythm strip. And by the way, anybody who knows me would know that I will not accept this EKG. Too much movement. I can't tell what's happening. Please do it again. Stop accepting something such low quality when you need to be able to look at this information. And I need a long rhythm strip. This is nice. I've got a rhythm strip, but it's really short, right? Our 12 lead is 1, 2, 3, AVR, AVL, AVF, V1, 2, 3, V4, 5, and 6. And down here, this is extra. Sometimes it's lead 2. Sometimes it might be more than one lead. It could be lead 2 and V1. Those are always good leads to look for P waves in. And a lot of times they're the leads that we're going to do rhythm strips. We only have one rhythm strip lead, that's lead 2, but it's too noisy. I can't read it. The patient is moving or the leads are moving. I can't really tell what's going on here, except that this is profoundly abnormal and it's taken a tremendous amount of time. Can't really tell anything else from that EKG, and I'm pretty good at reading EKGs. Now we look at our patient's labs. Okay, so first and foremost, if she doesn't receive dialysis, she needs to. Now she does receive dialysis, she just wasn't getting it that day. You can see her potassium is 8.3. Goes down to 7.5 and down to 7.2. That's in relationship to, she, I think at this point is still in the ECC. Okay. So this is really abnormal. You also are looking at her total serum CO2, which is her bicarb. That's really, really low. She has a normal anion gap, but how could that be? She's very acidotic, right? Her total CO2, which is bicarb, is very low, but she has a normal gap. There's reasons that her gap is normal. We can talk about those at another time. Okay, so now I'm going to go down here. I'm going to look at her lactic acid level, which is 4.7. And I'm going to look at her HS troponin. Okay, now that's amazing. Her HS troponin. So remember, in women, HS troponin greater than 20 indicates that there's been myocardial injury. Okay, and that myocardial injury may be chronic or it may be acute. That's why you must always do 1 hour later. So by the way, here's my first troponin at 4 a.m. My second troponin should have been drawn at 5. This is not when it's reported. This is when it was drawn, right? So her first one was 75. She should have gotten a second one at 5:06. Even if you haven't gotten the first one back, you do the second one because they should be within an hour. The reason is that many patients who have chronic cardiac dysfunction, and particularly patients with chronic renal dysfunction, will have a high HS troponin, but between the first one and the second one, there won't be much change. So we've gone a couple of hours here. Now we get that second one, 75 and 87. That's the HS troponin. So that's enough for me to be concerned. Also, her beta natriuretic peptide hormone is high, it's higher than 100. It's about, I can't see the whole thing because there's a bar with everybody's name on it, but let me go. Oh, 254. So it's high. It's not extraordinarily high, but it does predict the probability that my patient does have some heart failure. Not a big surprise. Okay. All right. So again, we look at that HS troponin. Now here's the first one, 29. That's the point of care. Then it's 75. Then it's 87. That's enough for me to want to take her to the cath lab. I want her to go to the cath lab. Okay, here's her next EKG. Okay, now it's not noisy, so that's great. Doesn't really appear much better than the first one, right? It's not much later. It's a much better EKG. But if I look at this, I would tell you that I can't make a case that the patient has P wave to QRS. I feel like this is idioventricular, which means that her ventricular impulses are what are promoting cardiac contraction, cardiac electrical depolarization, cardiac contraction. And what I want to do is speed that up. So I would probably myself would have considered giving her a little epi, maybe a little bit of atropine. I think folks are always a little bit nervous about that, but she's in an idioventricular rhythm here. And we can make a case that, and we do think we see some P waves here, and it's possible those are P waves. Can't say for sure. But when I look at this rhythm strip, I do not see any P wave correlation to her QRS. Even if I thought I saw it occasionally, it's not constant. Here's her 30 kg. This is about 3 hours later. Okay. She is still in this slow rhythm. Okay. Now, at this point, I need to make some decisions, right? The thing is that a problem for us is when we have patients who are in idioventricular rhythms, who have really slow rates, they actually are highly at risk for asystole. So a couple of things you can think about in this patient is that, first of all, she has a right bundle branch block configuration. She looks like she's in an idioventricular rhythm. I would like her heart to beat a little faster, but I don't want to stress her with epinephrine. Don't really want to stress her with anything that's going to increase myocardial oxygen consumption. I would probably do transcutaneous pacing here. And I would do that for the next hour or two until I kind of got everything stabilized and considered what was going to happen next. Now we look at her echocardiogram from 320. Okay, so no comparison study to any other time. What I want you to pay attention to, she has a beautiful LV. Her LV has got an ejection fraction of 60 to 65%. Now, she may not have a survivable cardiac output. Ejection fraction isn't looking at cardiac output. It's looking at the fraction of blood ejected by the heart per beat. Her beats are really, really slow, right? She's in idioventricular rhythm, but she's got a good LV. But the wall that divides the LV from the RV should always be bowed over into the right ventricle, and it's flat. That means that the RV is typically overloaded, that the RV is dilated. And indeed, I put these little checks here. The RV is dilated, moderate to severely dilated. I'm going to tell you severely dilated. When I look at her X-ray, I can see it's severely dilated. Okay. RV systolic function is reduced. Her left atrium is severely dilated because she has assumably either mitral regurg or mitral stenosis, and that's why her LV is dilated. Because her LA is dilated because her LV is fine, so the LV is dilated, but the right atrium is severely dilated. Now look at what she's got here. So not every valve is discussed. Maybe it was discussed on another page. She has mild aortic regurg. That means that she's bolusing her LV every time her LV is emptied. She gets some of that blood back. But she has severe tricuspid regurgitation, which means I expect to see a large V wave in her central venous trace. She also has pulmonic valvular regurgitation. So she has pulmonary hypertension with high pressure, pushing blood back into the RV. The RV is pushing blood back into the RA. She's as big as a boat. She's volume overloaded. She has terrible renal dysfunction because she does not have good forward flow. She has a great LV, but she's not getting the volume to the LV because it's all going in a backwards direction. That's really, really important. So my expectation, what I expected to see on CVP was a large V wave. Okay, she had a CVP catheter, but it wasn't hooked up when I first saw her. Okay, I would also expect to see regurgitation on the ultrasound, and I would expect that her veins would be significantly non-compressible because they're filled with volume. It's just that her volume's in the wrong place. And of course, this is going to affect her ability to maintain arterial blood flow and arterial pressure, because instead of blood going forward, blood is going backward. But remember, she still has a pretty good LV. That was really important. Okay. So this is not this patient. I'm so sorry to tell you, this is not this patient, but here's a CVP of somebody with severe tricuspid regurgitation. So you walk in that room, you say, well, something's wrong with that CVP. It looks like it might be in the RV. Now, there are some very discrete differences between RA pressure and RV, and they're quite well seen here. Again, I don't want to get too complex. Here's the thing. You're going to look at that and you're going to say, something's wrong with this. Okay, there are two things that could be wrong. The tip of the catheter is in the RV, and this is RV pressure, or my patient has severe tricuspid regurgitation. Okay, well, go look at the echo. Oh, severe tricuspid regurgitation. Pretty sure that's what this is. It's not tricuspid regurgitation. I'm going to look at the chest x-ray. It's pretty easy. I'm going to make those decisions based on reading. I don't have to look at the image of the echo and make a decision. I am reading the echo profile. Okay, on the chest x-ray, hopefully your radiologist has said where the tip of the catheter is, but you can also see the tip of the catheter typically pretty clearly. So we have to enhance our skills so that when we go to the doc, we say, look, I want to show you the CVP. Thought it might have been RV pressure, but the tip of the catheter is in the RA. And I believe you can see this little sludge between here. That's your C wave and your V wave. This is indicative of tricuspid regurgitation. Now I'm going to just remind you, blood always goes the path of least resistance. What do we know about our patient? She has pulmonary hypertension, high resistance to blood going forward. She has tricuspid regurgitation, low resistance to blood going backwards. She has pulmonic regurgitation. I hardly ever see that. Blood is going backwards. So her RV ejects in the pulmonary vault, it comes back into the RV, goes back into the RA. We're not moving blood forward. And this is part of the reason that she lost consciousness. I believe this is a major part of the reason that the patient had a cardiac arrest. It's really important to investigate these things and not to just write numbers down, but to really look at what they're telling you. Now look at this again. Remember, this is not her. This patient had a PA catheter. PA pressure is 42/24. That's pulmonary hypertension. CVP read by the monitor is 29, but actually her filling pressure, we have to exclude the V wave, is close to 0. Her filling pressure is close to 0. And the peak of this is at 70. Okay. Now that would make me think more that this is probably right ventricular. Again, I'm not going to make the full diagnosis without a lot of other information. And I always need my chest x-ray. And I always hope to have an echocardiogram to help assist me in making good decisions for the patient. Okay, so now we look at that EKG again at 3:48 in the morning. She has a right bundle branch block, and not really positive it's even a right bundle branch block. It looks like a right bundle branch block, but what it is idioventricular rhythm, which means it becomes very hard to differentiate all those things. And yet again, what I'm going to remind you is probably the very best thing for this patient would have been at this moment, or I'm not saying they didn't do it, I don't know, would have been to stimulate the sinus node. And your best stimulation of the sinus node is going to be with epinephrine. You can also stimulate with dobutamine. Both of those agents are going to significantly increase myocardial oxygen consumption. So I'm a little bit hesitant. She hasn't gone to the cath lab. I don't know what her disease state is. She's a chronic renal failure patient. She has a lot of electrolyte imbalancing. Probably for me, I would just say, yeah, I want to pace her around 60. If she has an accelerated idioventricular, which is almost where she is now, she'll overdrive that pacemaker. I'm just going to set the pacemaker up in case she has prolongation and an asystolic event. Okay. I don't know why we're going back to that. Okay. All right. So I go to see her and I say, oh, guys, you got a triple lumen. Can you hook up a central line? Okay. So central line gets hooked up. You can see her scale here. This is her 0 to 30. And here's her waveform analysis, right? Oh, how strange is that? Okay. Is our bag at 300? Are we level? Do we have any air in the tubing? You set it up really quickly. Ask all those questions. The answer is, oh, we've done everything right. We've done everything right. Want to remind you here that kind of have this very damp looking waveform, but let me tell you why. This patient, by this time, was already on Velitri. So she may have had a very large V wave, but they started on Velitri, which unloads the pulmonary vault, unloads the right ventricle, allows the right ventricle to empty into the pulmonary bed. As the right ventricle empties in the pulmonary bed, the regurgitation is significantly reduced. And so we can say treatment, my belief, the treatment of pulmonary vasodilation, she'd been on it for about 5 hours when I asked them to hook up the CVP. It was working. Now, I was here at the hospital, but I had already left the unit when they had done this, and they snapped this picture and sent it to me. And I said, can you put her on a smaller scale? Can you do this? Can you check this? Can you check that? And the nurse said, yeah, I'm really happy to help you, but I've got to go off to CT scan and do some other things with my patient. Okay, great. That no problem. All right. So now we're going to, she did well. She was really a candidate for ECMO. She had to be dialyzed. She had a lot of other problems. Now we're going to just look at this last little patient. Actually, you know what? I'm going to stop here because it's 5 o'clock. But what I want to say is, and I'm just got to move slightly through this, just a patient, a fantastic patient that we had in our medical ICU quite a long time ago. But I just want to remind you that you should always suspect RV dysfunction when your arterial-based cardiac output is low despite intervention, vasopressors, volume inotrope. If you have a PA catheter and an arterial line and you're looking at the measure of stroke volume and cardiac output, there'll be a wide differential. When you have RV dysfunction, your PA measures may be very high, your arterial measures may be low. Again, it's a really important concept beyond this talk. But here's what we talked about. If you've got a large V wave on your CVP, or you have a large A wave on your CVP, always suspect RV dysfunction. And the best way for you to support that patient is pulmonary dilation. So inhaled nitric oxide, Velitri, Flolan, those agents will be distributed at the pulmonary vascular vault with very little effect on the systemic vascular vault. So it decreases the work and tension that the RV must generate to move blood through the pulmonary vault. That's the first step, pulmonary dilation. So for most of us, it's Velitri, Flolan. Nitric oxide's more expensive, but if there's a choice or if there's failure, and that's really important. Again, if you're the nurse at the bedside and you have a big V wave and your patient starts on Flolan, that V wave should get smaller. It doesn't get smaller. You are probably failing your Flolan or failing your Velitri. Now it's time to talk about the big mother of pulmonary dilation, which is more expensive, but every single hospital that does pulmonary dilation has it. It's just expensive. And that would be nitric oxide. Patients fail Flolan, they fail Velitri, they need nitric oxide. And that's our next step. The other thing is, of course, we can consider some kind of mechanical circulatory support. Here at Grady, that might be an Impella RP. That might also be ventricular assist device. We don't do that here at Grady, but we would move our patient to Piedmont or Emory. And those patients who are refractory, right? Even if we reperfuse them, but they're not actually improving, they're going to get an Impella RP, a right-sided Impella, which basically sucks the blood from the right atria and pushes it up into the pulmonary vessel. And then, of course, you could just bypass this and go straight here to VV ECMO, where we're taking the blood from vein to vein and really bypassing the right heart and the lung altogether. Central vein to pulmonary vein, bypassing the right heart, bypassing the lung with VV ECMO. So again, depends on what you're able to do in your institution. For us, pulmonary vasodilation, mechanical circulatory assist. Then we got to try to get you somewhere else where they can do ECMO. Ultimately, we've been talking about it for years, but I think the time is coming nigh. We will be able to do some VV ECMO in particular cases, but you've got to think about ECMO. As soon as you have failure here, you should be talking about ECMO. You might do this as a bridge. You might give an Impella RP, you might give a VAD if you have that capability, but these are just bridges to ECMO. And then ECMO, of course, is ultimately, if you fail ECMO, it's a bridge to transplant. So again, pulmonary dilation, mechanical circulatory assist, VV ECMO, transplant. That's the journey. That's the journey. And it all started because you recognized that your patient had a big A wave or a big V wave in the CVP. You ruled out that it was clearly just related to RBB or RVH. It's the probability that you've had an RV infarct, or you have severe acute or acute on chronic pulmonary hypertension. You're going to see that big V wave. You're going to move fast. CVP is not a number. It is associated with waveforms, and we have to do the right thing for our patients in order to make sure that the right thing is being done. So I want to tell you very much how much I appreciate that you've attended here today. Those of you who are on the call, please stay online if you have some questions. Otherwise, I'm going to say thank you very much. And I'm going to stop my recording. And thank you. Hope to see you next week at Tuesday Topics.